Hello, everybody. Hopefully some people are, I guess, tuned in from my prior talk. So I'll try to give a little bit of, I don't know if it can be closure, it can't be closure, but a little bit of follow-up on some of the things I spoke about there. So I mainly want to share my clinical experiences and their slow and ongoing translation into evidence-based practice. But I'm going to be talking a bit about testing issues. I think Stephen Goff and I were just chatting briefly earlier, and he's saying, every person should have sort of a talk ready to go at any moment. And the timing was good because we just submitted a paper on this yesterday. So perfect timing to do a little bit of a talk before the reviewers get to it. But let's talk a little bit about testing, and this is sort of a paradigm to have in your heads. But I'm going to be talking about when the virus is present, when you can potentially spread it. I'm going to try to get through this quick enough so that we have a bunch of time for testing. I know we have for questions. I know we have about 200 people watching this, so hopefully some folks will get a chance. Just to go through the testing timeline, I've been pretty focused on testing for quite a while, and there was a recent PBS Frontline special, which was The Virus What Went Wrong, and there's a lot of focus there on testing. And I've been sort of pushing and involved with testing, I'll say, for quite a while, maybe since the beginning. Back in February was when we had a sense that there was community spread in the New York area, and that's since been confirmed. Organization was involved, and actually that first patient who was identified sent to a Columbia hospital, right, Lawrence, and then ended up at the mothership there, Milstein, in the city. But early on, there were all these issues with testing. In-hospital testing started early in March, but it was very restricted. And it really wasn't until mid-March that we really documented significant spread and finally got to this pause order. So what are the issues when it comes to testing? What's the importance of testing? A lot of the importance of testing, I'll say in my mind, is limiting undetected infectious days. And there's two aspects to this. And the first is, what is that infectious period? How long is someone potentially infected with the virus and able to spread it to another person? And so the data to date suggests that somewhere between 1 to 3 days before symptom onset, with an additional 7 to 12 days on average after symptoms arise, people are shedding virus. And that's not just PCR positive. This is, you can culture virus. This is potentially spreading virus, making another individual ill. There were some early data saying, we can only culture virus out to about 8 or 9 days. This was in outpatients with mild disease. Everyone was actually getting pretty close to saying, let's just use a 10-day threshold and not worry about these people and send them back to nursing homes, send them back into all these different settings where there are at-risk people. And then this group in the Netherlands basically said, some people, particularly people who are more severely affected, people who require hospitalization and other levels of care, you may be able to actually culture a viable virus out. They were able to culture a viable virus out to 20 days. So that infectious period is not just 10 days in everyone, it's 20 days. It might be even longer. We're still learning about that. So there's certain assumptions you're going to see as we go forward. And I talk about the concept of undetected infectious days. And the big thing here people are probably thinking about, which I will address, is that we actually think at least half, maybe much more than half of people who get infected are asymptomatic. They may continue to be asymptomatic the entire time, and those individuals have been linked to transmission. So, and this sort of brings this in, and this is actually that concept that many infections are asymptomatic. So I'm going to be talking a little bit about screening, not just waiting for people to be symptomatic. And this was a paper that came out actually we just hit July, so I guess this is old. This is from last month. But you can see when you look at a lot of these numbers, these are people who are positive, the percent that are positive but asymptomatic. And I'm going to zoom in here on our next slide, and actually this population of Virginia inmates, where actually 96% of them were asymptomatic. So the idea of reserving testing just for people with symptom is fraught with issues. We're not sure in different populations what percent are actually symptomatic and would be considered candidates for testing if we're not moving to an asymptomatic screening. So it might be 4%, it might be 50%. These are things we're still working on, but they're going to be different in different populations. So our model sort of looks at two issues. One, it's going to be how often do you just test everyone? Sort of saying that a percent are going to be asymptomatic or pre-symptomatic. So this is actually what I did is I tried to take our data that's going to come out and make it, I'll say, sort of simplified, straightforward, just so people get the sense of what we're trying to communicate. And the first thing I want to just talk a little bit about is the impact of testing frequency, because people talk about it, say, oh, maybe everyone should get tested. Next question is, how often? Is it once a week, say every 7th day? Is it every day? And tied in with this is, the issue of how sensitive is that test. And then I'm going to talk about this particularly on the next slide, is how quick do you get those results? So, in general, I'll say testing is still being driven by the profit paradigm in the United States. We had testing down to where we had average turnaround at about 48 hours, and suddenly that became longer. And when we looked into why that was happening, we realized that in the New York area, it was actually cheaper to take the tests, send them out of state, run the tests out of state where you could pay people less. And then that increased our delay to 3, 4, 5 days. So that's a little bit of an issue, but this is, back when people hadn't realized you could save money and delay the testing results. So this is assuming a 12-day infectious period. This is a 99% sensitive test, which we don't have. And this is assuming about a 2-day delay in getting those results back. And you can actually see, if you're looking at a screening where you're just testing people once a week, you're only getting a minority of infectious days. The majority of infectious days, the majority of spreading events are not going to be captured with that. Even if you go to daily testing, with that 2-hour turnaround delay, et cetera, you're still having an issue. So there's more complicated modeling that people can see when our paper sees the light of day. The other is the impact of result delays. And this is an issue as well. Right now, we're, I think, still probably the organization with the largest testing capacity in the New York area. So this is ProHealth. Which is sort of it's under UnitedHealth Group. And if you assume a 12-day infectious period and you have no delay, right, you can get it right away once they have symptoms, right? So this is assuming you're actually just testing symptomatic people. So you've got in this graphic, the first couple days, no symptoms at all. Then you start to feel poorly, so you decide to go get tested. Now you get tested, and you get your results right away. Well, you've of course missed this zone here where you didn't have symptoms, you weren't triggered to be sick enough to go get tested. But then as you introduce each delay, the person may have gone to get testing here, but they don't get the results for a couple days. And so, you very quickly lose, even with just a 3-day delay, about half of the infectious days from being captured and prevented, right? While a person is infectious but not aware of it, they're not self-isolating. Sometimes they are. I will say some healthcare providers, as soon as they get symptoms, are really good about self-isolating. I was taking care of a patient yesterday in Houston. Now with telehealth, we sort of can extend and help people in harder hit areas. But yeah, most people are not self-isolating, are not doing what would be needed to be done to prevent spread until they get that positive test. And if you're not screening every day in certain populations, and if there's delay in getting those tests back. So I think there was just something that came out today. I don't think there was something that came out today saying that there's only about 14 states that are considered to have adequate testing. I'm going to say I'm not sure they're having adequate testing, because New York is considered a place with adequate testing. And if you look at the delays in getting your testing results back, our hospitals have had issues recently with running out of swabs, running out of supplies, because they're all being sent down to Florida. And so when you start introducing those result delays, that's a problem as well. And we certainly do not have large screening programs in place. So hopefully people have some questions on that. But what I'll do here is just run through some of the stuff, the observation to practice. Last time when I spoke, I talked a little bit about the observations. And since then, we've actually learned quite a bit. We're starting to get, we'll say, indirect low quality evidence and also some good randomized control evidence. So pulmonary support, I described in my last talk about how we were seeing or observing or seemed to be observing that once someone was intubated, that people did not do well. Now we're seeing that that is actually confirmed and doing a lot more to delay people being intubated and using a lot of non-invasive ventilation. We also identified early on that there were issues with this cytokine storm, a pretty significant issue with the immune dysfunction occurring. And now, actually, this I think was pretty impressive, good, solid, randomized controlled data supporting the use of steroids. And on one of the TWIV, This Week in Virology episodes, we actually talk about the history. Like, well, why was everyone so dogmatic anti-steroids? What was sort of that history over time? What got us to where we are now? But we're now seeing, not for everybody, but in patients that require oxygen, we're seeing significant reduction in mortality, whether they're on the floors, whether they're being managed at home on oxygen, or whether they're on a ventilator. The immune modulation's gone a bit further, and we're starting to see a little more evidence to help us with IL-6 receptor targeting. So tocilizumab, we're getting a little bit more data there. Poor outcomes, right? Things were pretty bad back in March when this got published in early April. You know, of the admitted patients, only about 36% were being discharged alive, and of the ventilated ones, this is the Northwell study, about 3.3%. And you could see now some of the outcomes coming out of Yale, where they're actually using a combination of steroids in some patients, tocilizumab in other patients, anticoagulation in other patients. And we're starting to see that actually these are much better survivals than we were experiencing back in the early days. Anticoagulation, we had identified early on both venous and arterial. And actually now there's a lot of recommendations coming out along these lines where we're actually seeing an association with improved in-hospital survival in patients on full-dose anticoagulation. And actually a reanalysis of the Mariner data is supporting that patients be sent out from the hospital on long-term, a minimum of 45 days, and this may be extended to 3 months. So just a summary of current practice, we've learned a lot, just 2 slides to go. There's a lot of things we're not using. We're not using hydroxychloroquine. We're not using much in the way of famotidine or azithromycin. It's a virus, not malaria and also a bacteria. Little bit of remdesivir, steroids, tocilizumab, anticoagulation. And we are wearing masks and eye protection. And yeah, it's hot, it's hard. I went for a run the other day in a mask and I thought I was gonna suffocate, but you know, we can all do our part. So for more information, parasiteswithoutborders.com, we try to keep a lot of updated articles there so you can read the whole article, don't just read the title and abstract. We do our weekly updates on This Week in Virology, try to keep people up. And then at any point, feel free to reach out to me. So thank you very much.
Yeah, that was an awesome talk. And a number of us have been pushing really, really hard for months to get testing done at Columbia. And we have pretty much given up hope and agreed that we've lost. And I just wonder whether you've shown your data to Bollinger and other decision makers at the university. Because I think it's a very powerful argument that we are correct that we need to do testing.
Yeah, no, I've been in touch. Actually, Magda, and if people know Magda, the chief of ID at Columbia, she and I talked a lot early on because testing is really hard, and testing is really hard in an urban environment. We have certain advantages, right? ProHealth is spread through the whole tri-state area, so within just a few.
I'm talking about specifically at CUIMC.
Yeah, yeah.
So when people coming back to work, for example, they're proposing to do a single test. And we know that that's absurd, and your data, and yet that's where
Andy, you put it so delicately.
The greatest university in the middle of the pandemic is, really blowing it. So I just wonder if you've had a chance to show decision makers, these data, because they're so beautiful.
Oh,
And
thank you. I'll keep sharing.
I'm sorry, what?
I'll keep sharing. Anyone who will listen. But yeah, I'll keep, and I think this will hopefully come out soon. So, and there's actually, I think another group was putting out another. So a lot of this modeling is important to point out the frequency at which you need testing and the importance of the turnaround. So frequency, turnaround, these are all really critical.
Also, your comment about the profit motive, I think, is something that hasn't been admitted to, and it's really quite startlingly upsetting. But I will let other people talk. Ashley, if you unmute yourself, you can ask a question.
Hi, Dr. Griffin. Just a point of clarification. Did you say that New York City is outsourcing the tests to Florida?
No. So I'll clarify that. So a lot of the testing is done by, we'll say, national groups like LabCorp, like Quest. And so just a few weeks ago, I noticed that we had an increase in the turnaround time because I always try to keep track of what's the turnaround time from testing to results. And when I looked into it, I won't mention whether it was LabCorp or Quest, but they had realized not sending them to Florida, but sending those tests over to New Jersey, where it was apparently cheaper to run the assay. So that was one issue. The other was in the last week, we noticed that we're having delays that were introduced in the hospitals as well. And that was an issue of reagents and testing components being sent to Florida, Texas, Arizona. So we were not getting the same supply that we had gotten before. So tests out of state to save money, and then reagents sent to areas that were sort of having these increasing demands. So, people always talk about waves and such, and we're up to over 40,000 new cases a day, and that's a lot of testing that needs to be done. A lot of these states that are not doing well, they're seeing greater than 10% of the tests they do coming back positive, which just means we are doing nowhere the number of tests that we need to really know who has this virus.
I see. Thank you for the clarification.
Certainly.
Can I ask? Yeah. Hi, Ashley. So I was on a Zoom with Janelia, and we talked to a microbiologist who's both a clinician and has a research lab at the Hutch. And it's this issue of whether one should test every day. And he said that he had pushed the Hutch to do it, but they had run a financial analysis, and it would just basically be so costly to test everybody every day that they'd have to shut down their research protocols. So I really think at this point that putting a lot of effort into the sort of things that Chris Mason and Andres Bendeski are doing, these home lamp-based colorimetric assays, might be worthwhile. Engineering them so that they're reliable and idiot-proof is really difficult, but really if we don't test everybody every day and prevent people who are shedding virus particles from coming into work, we're just going to be chronically with this virus. So I think that would be the most useful approach to take, because you're right, a single test is absolutely absurd.
Yeah, no, I appreciate you bringing the economics, right? Like we've all started to have to think sort of beyond our small boxes, and the economics are huge. Who's going to be doing these tests? How are the tests going to be done? Who's going to pay for the tests? We just sort of had an ad hoc discussion when you compare the trillions of dollars dumped into the stock market versus the billions of dollars it would take to do daily testing. There's an economic argument. Maybe someone will publish sort of a modeling on this. What's cheaper, to have the economic shutdowns we have or to ramp up testing?
I think everyone knows the answer. Margaret.
Yes.
Hello, just hi, chiming in on this question. Look, it strikes me that that these non-policies add up to stuff that we just simply don't want to accept. And the reality is we have a president who said stop testing because he didn't want the information and the data that comes from testing for economic reasons. And, I'm sorry, I don't have a whole lot of faith at this point that we're going to get rigorous testing because of the economic imperative. And I'd like to know how you feel about that from your perspective.
No, I was sort of entertained as you were asking that, because I remembered in the end of March, our organization, we formed a COVID task force, and we actually got everything ramped up in February. The reason we could do the number of tests that we did is we basically went ahead and we went through procurement, and we got everything set up, and we're ready to roll out those drive-through testing, because I think for a lot of people this was anticipated that we were starting to see spread and we would really need a lot of testing. And then when we had established it was community spread, the head of our task team actually got a call. I won't say who it was from, but they said, would you please stop testing because you're making New York look really poorly? And it was from a politician. And he called me sort of like, I'm not sure what to do. And I said, well, let's think about this. Are you a doctor? Are you going to do what's best for your patients? And he was a slight pause and he said, okay, we're going to keep testing. And so, yeah, there is a political will to say, please stop testing. It makes us look bad. But that doesn't make it go away. You know, if you don't get your pregnancy test, you're still having that baby. And it's the same with COVID-19. Whether you get the test or not is not going to affect your chance of dying or not. But if you get that test, you know you have it, and it's going to prevent you from spreading it from other people. And hopefully, if you have it, now that we know a little bit more, it can guide treatment. So yeah, you got to keep testing. Even if there isn't political power here, we've got to sort of make it happen without that leadership, or even despite that leadership.
One more question, Dean.
Yeah, so I just want to put on the table that the economic models are based on the fact that we are dependent on commercial companies to do testing. We all know that in the academic center, we can do it for much, much less. And that has to be explored for us for testing to be sustainable through the crisis. And that's all.